This lecture into three parts. First, we will take the management of the distal phalangeal fracture, then middle, and then the proximal phalangeal fracture. So, if we go by systematic way, you will be able to have a journey through all the phalangeal fracture. So, what are the distal phalangeal fracture you come across? One is the tough fracture. The fingertip has been jammed somewhere, and there is just a phalangeal tough fracture with some nail bed hematoma. Then you have a phalangeal shaft fracture. Then you have a crush injury associated with the phalangeal comminuted fracture. Here the soft tissue component is more important. Can I get the pointer? And then there are avulsion fracture. Like this, there is a jersey finger and the mallet finger. This is another whole topic. The Professor Kotwal will be covering on this subject. Then there can be a non-union in the distal phalangeal fracture also. However, I am not going to talk about the malunion and non-union of the phalangeal fractures. How to manage the tough fracture? If this is a simple tough fracture with no compounding, no soft tissue injury, you can just manage with the aluminum splint. This aluminum splint will not alter the outcome, it will prevent the pain by striking the finger somewhere else, and it gives a protection during the 3 weeks period of the time. So, a supportive alufoam splint bent 90 degree at the tip is the treatment of choice for the tough fracture. When you have a crush injury like this with a fracture over here, the problem is more of a soft tissue management. The management of the soft tissue is primary importance. The fracture heals automatically, it doesn't require anything to the fix, and coverage with the flap and all this thing gives a good fingertip coverage. It's not coming over here anyway. When you have a shaft fracture, you can see there is a displacement of the shaft with the nail bed laceration, with the fracture doing displaced polarly. This unstable fracture after repair, before repair of the soft tissue should be fixed with a K-wire. Once you fix with the K-wire, stabilize the fracture, the soft tissue fall back in its own anatomical position, and repairing this will result into the good cosmetic finger and a good function. But rarely, if you improperly treat the distal phalangeal fracture, like there is a primary displacement with the soft tissue interposition, you may have a double nail deformity. There was a unhealed wound in the epineuchial fold, and the germinal matrix started producing the nail in this direction and that direction also. So this type of fracture and non-union and a problem with the epineuchial fold, if properly treated by the nail fold excision, coverage of the flap, results into the good healing distal phalanx. I am not able to see the completely over there. पूरा कवर नहीं हो रहा, उधर नहीं आ रहा है पूरा. Okay. It's not moving. Yeah, let's talk about the middle phalangeal fracture. The neck of the middle phalangeal fracture is the one of the most common fracture. It almost always in conservative line of management, if you don't observe it closely, it goes into the dorsal angulation. So what to do? This fracture initially started with this, and this has gone into the dorsal angulation like this. And why there is a dorsal angulation in this type of fracture? This slide and principle I have borrowed from Dr. Sudhir Warrior sir. See, when there is a dorsal angulation, the lever arm becomes advantageous on the dorsal side. The extensor pulls the whole fragment dorsally, and there is a resulting into the more dorsal angulation. The flexor digitorum superficialis pull on this side proximally and on the flexor surface, and because of this beak of the proximal phalanx, the flexor digitorum profundus is not working to the advantageous position. So hence the fracture goes into the dorsal angulation. So these type of fracture should be fixed with the K-wire so to prevent the dorsal angulation. When you have a middle phalangeal fracture like this, with some of this having a displacement like this, she is an elderly lady, 60-year-old, and at 10 days she came with this type of range of motion for the first time. Should we treat by operative means? I think probably no. Looking at the range of motion what she is having now at 10 days, diabetic, 60-year-old, I would prefer to treat it by conservative line of treatment. Not the X-ray is every time important. You have to look at the condition of the patient. The basic idea is if patient is having a stable fracture and able to do the good range of motion without overriding the finger, you can treat them conservatively. When you have a middle phalangeal base fracture like this, if you look at the APN lateral X-ray, it looks to be a benign fracture. If you look at it, most of the people would like to feel it as a, oh, you can manage it by the conservative measure, just put the splint. But look at the oblique view, it shows a gross comminution. So if that much, this is one fragment, this is another fragment, this is another fragment, this is another fragment. In this type of cases, a traction view of the fracture is important. That shows amount of actually comminution along with the what reduction is possible with the traction view. And this fracture, if given a traction view and find to be in a good anatomical alignment, just maintain the traction in by the putting an external fixator device for 3 weeks and look at the thing, then it is not coming over here. The patient is a full range of motion. He is a doctor, he has the full range of motion. So look at the fracture geometry. If it is possible to fix it. If you can give the good view in the traction and anatomical reduction or close to anatomical reduction with a good articular reconstruction, fix. There is no definitive way of treating one fracture. The idea is to get a good anatomical alignment, good articular surface reconstruction, and maintain the congruous joint reduced position. When you come across a base fracture like this, there is a central slip avulsion over here. This is a 10 days or 14 days old compound fracture of the base of the base of the proximal phalanx. What you need to do is, you need to reconstruct the articular surface so that the patient can have a surface where the actual gliding is possible, and fix that so that the things come into the position. Again, a percutaneous screw fixation to maintain the things into the alignment, and once you have maintained the line, to prevent the axial loading and disruption of the phalangeal base fracture, you put a neutralizing external fixator, and that can be the outcome after 3 months. Another fracture, grossly disfiguring to any of us. What to do? This is displaced, this is displaced, this is volar fragment, volar plate avulsion, this is central slip avulsion, and this fracture is like this. How to approach this type of patient? These are really tough fracture to deal with that. So the thing is that what you do is, you try to fix one, make it a 3-part fracture into 2-part fracture. Whatever you can do close, you try. What I did in this, I tried to give the extra traction, and once the traction I can achieve some reduction, I put percutaneous screw from dorsal to the shaft obliquely. Once I achieved this dorsal configuration, I opened from the volar side and put another screw from volar side. And sorry, this is not obvious over here. 2 screws percutaneously fixed from the dorsal fragment to the shaft, and 1 screw volarly fixed from the volar side to the dorsal side, and ultimately we could achieve the anatomical fixation. But is it sufficient? Probably no. You require to protect this fixation, because how much the load 1.5 screw is going to take. I don't prefer the plate because of the tendon adhesion and all the problem, because plate itself is having some amount of thickness. So to neutralize it, I put the external fixator, and ultimately the patient has a very good functional outcome with this type of gross looking fracture. When you have a fracture like this, base of middle phalanx, head of the proximal phalanx with grossly unstable fracture over here and all this thing, you need to reduce it as much as possible anatomically with a K wire, and then I again fix it by the external fixator and neutralize it, so to prevent the load on the fracture, because K wire in oblique position is not sufficiently able to handle the load. To neutralize this, put a fixator on that, and 3 weeks take out everything and start the range of motion. One have to be very careful when you are putting a fixator. You have to be through the safe zone. I think the Dr. Warrior will tell you about the some tips and tricks about the external fixator. Now we come to the proximal phalangeal fractures. Let's start with the condylar fracture. One of the very common condylar fracture of the proximal phalanx. It looks to be undisplaced, but if you take an oblique view, it's potentially displacing. This type of fracture are having a very high chances of disruption and displacement. If you want to treat undisplaced fracture like this, conservatively, you have to be very vigilant. Every 5 days you have to take the X-ray so that it is not going into the displacement. But the safer solution for this type of fracture is a percutaneous fixation, either by K wire or whatever you want to do, whatever the fixation you want to do, and protect with the splint. And another fracture like this, which is grossly displaced from the beginning, and if you want early mobilization, you can fix with the screw and start the mobilization as soon as once the fracture pain, hematoma, swelling subsides. And these are the range of motion you can achieve with this. Very unusual fracture. It's like a Barton fracture, volar Barton of the distal radius, volar rim fracture. This fracture, condylar volar chip has been avulsed both the side, both the radial and ulnar. It is not fixable by any of the device. When I opened it up, I couldn't fix it with anything what else I can do. So what I did, I just opened it up, debrided this fracture fragment, reattached the volar fragment, reattached the volar plate, and start the day 1 mobilization. After, sorry, not day 1, day 3 or day 4 mobilization with this splint, so that the patient at least from the beginning can start the range of motion. And I don't think there is any way we can fix this type of fracture. The key to success in this type of intra-articular fracture is the early mobilization, if possible, if you are not able to do this thing. Now coming to the shaft and proximal shaft fractures, how to fix that? The percutaneous K wire from the base of the proximal phalanx going in this direction and this direction up to the subchondral bone is the preferred way of treatment of this type of fracture. There are a lot of people who put the wire from this end to this end. Believe me, this is the most possible wrong way of putting the K wire fixation to the proximal phalanx, because here you violate the central slip, the PIP joint is put into the flexion position, and all sorts of problem with the stiffness of the PIP joint and range of motion come with that. So you analyze this fracture geometry, put the K wire from base of the proximal phalanx going in the opposite direction subchondral bone here to here, and if you bury the K wire subcutaneously, you can just give the dorsal block splint and start the early range of motion. The idea how much the range of motion we can permit is to prevent the tendon adhesion to the fracture site. The 1 centimeter of the gliding of tendon has to be there. If you have a 1 centimeter of the gliding of the tendon, just by giving a 30 degree of range of motion, 1 centimeter gliding is there. This 1 centimeter gliding is sufficient to prevent your tendon adhesion and stiffness. When you have this type of fracture, crush injury, all this thing, and patient has already come with this type of fixation, should we revise it? Yes. Whatever possible way, you should reconstruct the articular surface like this. Again, from base to the head, all K wires from base to the head, do as much as possible reconstruction of the articular surface and start the early mobilization. Early mobilization is key to prevent the stiffness. Whatever the joint you are not having stabilize it, you start the mobilization and prevent the tendon adhesion to that. I have seen this patient, it's not primarily operated by me, 3-4 fractures over here, and all have been fixed like this except for this fracture. So is that the correct way of fixation? No, this all has gone into dorsal angulation. Then there is a lot of stiffness. All the lateral bands has been adherent to the skin, to the bone, and this wrong way of fixation has to be condemned. Absolutely no way you should fix this type of fracture, because you are not able to stabilize it properly, and if you start early mobilization, you are likely to disrupt the fixation, and the problem with the early mobilization is that all the lateral band on both the side has been adherent to the bone now. Again, look at this fracture, which is twisting injury. In one view it doesn't look that bad, but when you take the traction view, it looks grossly disfiguring. How to manage this? Just putting the external fixator may not work on that, which is commonly a question to be asked. And if you just, this is the traction view which we have taken. Fracture. Two possible best outcome needs open reduction, internal fixation, as well as bone graft to reconstruct the articular surface. So when we opened it up and fixed with the multiple K wire and allogenic bone graft was put, and on table this was the motion, so that we can start the early mobilization in this type of patient. And look at it, what we started from here has been able to achieve this type of fixation by open reduction, internal fixation, and allogenic bone graft. When you get this type of fracture in a subacute position, at 3 weeks, this patient comes with the angulation. Can we make it? Yes, you can break the fracture and still put the percutaneous K wire from base of the proximal phalanx distally and still achieve a good correction and result. Condylar TY fracture, try to do as close as possible without opening the fracture and fix it, and this will have a good result at the end of the day. So what is the take home message for this type of phalangeal fracture? All stable and undisplaced fractures should be treated conservatively. There is no need to operate all undisplaced and stable fracture. If the patient is having a good range of motion of the finger without the overriding, it's a stable fracture and it can be treated conservatively. And all unstable fractures should be stabilized. Proper position and duration of immobilization should be understood. Early mobilization is a key to success whenever is possible. Hand therapy play an integral role in the operative and non-operative management. Thank you very much.